Hello, everyone. Thank you so much for coming today for our first webinar in the CAL seminar series in 2020. We're so delighted to host today Dr. THonda from the University of Utah School of Medicine. Trent is an associate professor and the division chief in the Department of Family and Preventive Medicine at the University of Utah School of Medicine. And his excellent work is actually primarily focused on quantifying the association between the environmental exposures and disease markers that may represent a causal intermediates between environmental exposures and clinical cardiovascular outcomes. Thank you so much, Trent, for coming today. We know it's quite late in Salt Lake City, and thank you. We're really looking forward to hear you talk today.
Thank you very much. I'm really excited to have been invited. Today I'm going to be talking about associations between built environment characteristics and disease biomarkers in older US adults. And I would say this is relatively early in this study process. And this is one of 3 studies that my research team right now is working on. I say that because any feedback that you're able to give us on the method or the approach would be greatly appreciated so that we can increase the quality of our work going forward. Oh, let me see if it's going to let me actually advance the screen here. Okay, so these are the 2016 and 2017 causes of mortality in the United States. And interestingly, if we look at the highest number of causes of mortality, most of these are occurring in older adults. And the vast majority of them are associated with inflammation or are diseases associated with inflammation, and also diseases that are associated with diabetes. And so if we talk about the previous literature looking at inflammation and disease, inflammation has been strongly related to a wide range of outcomes, including cardiovascular disease, cancer, hypertension, and then type 2 diabetes. And then diabetes is also known to be a major cause of cardiovascular mortality, contributing 8.8% to total CVD mortality in the United States. And in the US, unfortunately, we have a prevalence of over 20% of diabetes mellitus in older adults. And it's known to increase the risk of cardiovascular death by about 70%, myocardial infarction by 80%, ischemic stroke by 50%, as well as a number of other outcomes that lead to morbidity and mortality. In the US, the cost, both direct and indirect, estimated by the CDC was over $200 billion. And so my interest really is there an impact, a measurable association between green space, urbanicity, and then inflammation and glucose? And there's some prior literature, most of it is relatively recent, that looks at these associations. So in a 2019 study, there was no association found between green space and inflammatory markers, which included CRP and fibrinogen. In a 2014 study, there was a positive and significant association between urbanicity and inflammatory biomarkers that was found. And then again, in a very recent study, it was found that neighborhoods with higher green space were associated with lower hemoglobin A1C and odds of diabetes mellitus. And so some potential pathways exist to explain these associations, particularly around green space. Increased green space can be associated with decreased psychological stress, decreased pollution and noise, as well as increased opportunity for physical activity, whereas urbanicity can be associated with increased psychological stress, increased pollution and noise, and then decreased physical activity. All of these could lead to increases in systemic inflammation. And then if we think about the pathways for glucose perturbations, it's possible that all of these both impact glucose independently, as well as impact glucose through systemic inflammation. So in order to look at these, we identified a few biomarker outcomes, specifically looking at CRP, which is a well-studied biomarker of inflammation. And we used blood spots in our study, which have been shown to be greater than 98% correlated with venous sampling. And then consistent with previous literature, we restricted the CRP measurements to those that were less than 10, so that we were excluding people who had acute inflammatory infections or diseases. And then because of the distribution of the outcome, it was log transformed before we modeled it. We also looked at hemoglobin A1C, which is a clinical measure of long-term average serum glucose. In our study, we had blood spots that were greater than 92% correlated with venous outcomes. And the nice thing about looking at hemoglobin A1C is that while glucose will vary dramatically throughout an individual's day based upon their diet, what they eat, what exercise they have, the hemoglobin A1C has a direct linear relationship with the average glucose level, which allows us to get a better indication of this person's overall glucose homeostasis over time. And so the specific aims of our study was to assess the associations between green space, urbanicity, and distance to roadway as our markers of the built environment with biomarkers of inflammation and glucose elevation in older adults. And our a priori hypothesis was that green space and distance to roadway would be inversely associated with disease biomarkers. So as green space increased, we expected CRP to decrease and hemoglobin A1C to decrease. And then as distance to roadway increased, we expected that to occur as well. And then urbanicity, we expected to be positively associated to increase markers of systemic inflammation as well as hemoglobin A1C. Aim 2 of the study was to examine whether and to what extent the impact of these environmental factors are modified by participant characteristics. And our hypothesis, based upon previous literature and then our previous knowledge of these data sets, is that non-white and diabetic participants would have larger impacts from all exposures relative to white and non-diabetic participants. Aim 3 of our study was to examine whether and to what extent the impact of green space and or urbanicity on CRP and hemoglobin A1C is mediated by air pollution and or physical activity. So in a previous study by our research group, we had identified that the impact of urbanicity was significantly mediated by estimates of air pollution in the area. And so that's what led to this hypothesis that urbanicity and green space that air pollution and physical activity would mediate some of the association between urbanicity, green space, and the biomarkers we're looking at. And so the study population we looked at was the National Social Life, Health, and Aging Project. This is a NIH-funded study out of the University of Chicago that is a nationally representative sample in the US, incorporating over 4,000 community-dwelling US adults, all of which are over 57 years of age. And it oversamples African Americans, Latinos, men, and those that are considered the oldest old. And particularly, this allows us to explore in our hypothesis the differential effects for race, which is not always possible in US studies that don't oversample these populations. There are 2 waves of data available, and then the outcomes and covariate data was collected by blood spots and then questionnaires. So now I'll talk more in detail about aim 1 and our results. Aim 1 again is the association between green space, urbanicity, distance to roadway, and our biomarkers. And our exposures of interest included the normalized difference vegetation index. This is the ratio of the difference between the near infrared and visible radiation to the sum of these 2 measures. And as you can see on the picture on the right, the higher amount of green space you have, the higher the NDVI. And we obtained these data from some NASA satellite information. The range for NDVI is -1 to 1, and the larger values indicate greater vegetation in the surrounding area. And we linked these to the residential addresses of participants in the study using a 1,000-meter buffer around each participant's residential addresses, accounting for moves that occurred between wave 1 and wave 2. For our urbanicity exposure, this was based upon the percentage of low and high intensity residential and industrial transportation land use that was linked within 1 kilometer of each residence. And we obtained these data from the US Geological Survey National Land Cover Dataset. For our distance to roadway exposure, we used the StreetMap Pro function in ArcGIS and looked at the distance to roadways A1, A2, and A3, which are larger roadways, smaller, and then the secondary roads were A3. And again, we accounted for residential moves over study time period. So our analytical methods were linear missed effects regression models, adjusting for a large number of potential confounders, including age, BMI, race, region, the size of the municipality, the season and the year that the blood collection was done, the socioeconomic status, including participant education, as well as a large number of neighborhood income variables, including the zip code percentage of people below the poverty line, the percentage of people who had a bachelor's degree or greater, and then the median household income in the census tract. Behavioral variables included smoking and alcohol use. Medical history included diabetes status, hypertension status, and medication use. And then potential mediators included physical activity, PM2.5, and NO2. We used inverse probability weighting to account for missingness, as well as the complex survey design. And then we examined exposure response curves using natural cubic splines. So our cohort demographics, you can see as a relatively high mean age of around 70 and a little bit less than 50% male. The average BMI was close to the obese metric, and about 21% of people had diabetes, and close to 60% had hypertension, which is very consistent with the national data for the US, which is reassuring that we're looking at a nationally representative cohort. Our CRP results, here we can see our linear regression results, looking at the NDVI and CRP. And here we looked at the NDVI as an IQR increment using base, intermediate, full, and then full plus mediator models. And down here at the bottom, you can see what covariates were included in each of the models. And you can see that per IQR increment increase in NDVI, we see a significant decrease in percent CRP, with the full model having almost a 15% decrease in CRP, with a suggestion of a dose response curve based upon the P-for trend test. Now, the associations were rather significantly decreased when we included the potential mediators in the model, but we did still see an independent effect when we did this. And if we look at the dose response curve, we can see that there's really no suggestion of nonlinearity in the association between CRP and NDVI. Now, when looking at urbanicity in CRP, we do see that an IQR increment increase in urbanicity is associated in base, intermediate, and full models with decreases in CRP. And this is the reverse of actually the hypothesis that we had. And then we don't see significant effects in the second quartile and third quartile of exposure, but we did in the fourth quartile of exposure. Interestingly, when we included the potential mediators, though, we found that our associations became non-significant. And this is the urbanicity exposure response curve. Now, for distance to roadway in CRP, we found no significant associations in any of our models, base, intermediate, full, or full plus mediators for distance to A1, distance to A1 and A2, A1, A2, and A3 roadways, and then looking at just a binary exposure of living within a 100-meter buffer from a A1 or A2 roadway, or not living within that buffer zone. So those were our CRP results. Now we'll look at our results for hemoglobin A1C. For greenness and hemoglobin A1C, we found largely null results where increases in greenness were not significantly associated with hemoglobin A1C, except in our full plus mediator model where we found borderline significant increase in hemoglobin A1C associated with an increase in the NDVI, which again is the reverse of the hypothesis that we had for this. When we looked at urbanicity and hemoglobin A1C, however, we did find in our intermediate and full models that an IQR increase or increment increase in urbanicity was associated with a 1% higher CRP in our full model, although this became non-significant when we included our potential mediators. If we look at the urbanicity hemoglobin A1C exposure response curve, we see that essentially we have a null result. We can draw a straight line through those confidence intervals. And consistent with our distance to roadway CRP results, we found that distance to roadway and hemoglobin A1C are non-significantly associated. So that was aim one, looking at the associations between greenness and built environment characteristics and CRP and hemoglobin A1C. Our aim two was to examine for effect modification. And we examined this by including multiplicative interaction terms into our model, and then evaluating for significance of this interaction term using the likelihood ratio test. And we examined 4 different potential effect modifiers based upon previous literature, including BMI obesity, race and ethnicity, age, and type 2 diabetes. And here we've reported the only association where we had a significant association with NDVI and CRP, and this was for race and ethnicity. And in this effect modification model, we found that white individuals, Hispanic individuals, and Asian and Native American individuals all had significantly different associations, but the highest associations were found in Hispanic and Asian and Native Americans. It's interesting that the increase in greenness would have a differential racial effect for the effect on systemic inflammation. When we looked at urbanicity and CRP by race and ethnicity, we found that the only significant association was observed in white individuals. Now, looking at effect modification models for hemoglobin A1C, we found that urbanicity was significantly associated with increases in hemoglobin A1C among white individuals, but it was a much higher association found among Black individuals. And aim 3 was looking at our mediation models, where we are interested in determining whether or not the effect of NDVI and urbanicity on CRP and hemoglobin A1C may be mediated through the effect of air pollution and physical activity, which is consistent with some of the previous studies that we've done on this population. And our air pollution metrics for PM2.5 were based upon a national spatiotemporal model that was published in 2014, where we used lots of different exposure metrics, as well as population density, point source emission sources, and put these all through a spatiotemporal generalized additive mixed model to come up with participant-specific air pollution exposure estimates that accounted for moves across different waves within the study. Our NO2 exposure estimates were not based upon a spatiotemporal model, but they were exposure estimates based upon the nearest air quality monitor that was restricted to less than 80 kilometers from residential address. And then in sensitivity analyses, we restricted to 60 kilometer and 40 kilometers. So this is just to say that our PM2.5 measurements are probably subject to less exposure error than our NO2 estimates for this study. And the only significant mediation that we identified was a 8% mediated effect between the neighborhood greenness and CRP by physical activity. And in order to do this analysis, we used the causal mediation approach by Tyler Vanderweel, published in 2014. So now for the discussion. Our neighborhood greenness and urbanicity we found to be associated with CRP, while distance to roadway was not. The inverse association between NDVI and CRP was consistent with our hypothesis, and we observed a linear dose-response relationship. And interestingly, we found the strongest associations with Hispanic and Asians and Native American populations. And when we controlled for the potential mediators, we found that there was an independent effect, or the effect that we observed of neighborhood greenness was independent of the air pollutants. Now, with urbanicity, we found the inverse association, where increased urbanicity was associated with decreased CRP, which was not consistent with our a priori hypothesis. We again observed a linear dose-response relationship. And when we looked at associations by race, we found that the effect estimates only remained significant for white participants, which may suggest that there's differential impact of urbanicity on CRP by race. Now for hemoglobin A1C, we found mostly null results when we looked at neighborhood greenness and its effect on hemoglobin A1C. There was the suggestion that higher urbanicity was associated with higher hemoglobin A1C levels, and this was particularly seen in Black participants. And our mediation of results, there was a suggestion that green space, the green space association with CRP may be partially mediated by physical activity, although the percent mediated was relatively small. So there are a number of limitations to our study because we're looking at just over 4,000 people across 2 waves. We have a relatively small sample size, which may impact our power to detect effects. There's potential residual confounding because we do not have information on important confounders such as diet, which would potentially affect both of our outcomes. And strengths include we're using a nationally representative sample, and then we had high quality exposure estimates for both urbanicity and neighborhood green space. And I'd like to thank the people who contributed to this study and our funding sources. And thank you guys for taking the time out of your lunch breaks, I imagine, to listen.
Thank you so much, Trent. That was quite interesting talk. Thank you so much. Really appreciate your time and all the interesting results you presented today. And I'm gonna open the platform to our participants if they have any questions.
Hello, it's Anne from Griffith University in Queensland. Thank you, Trenton, for the talk. I'm very interested in this whole association between green space and how we measure that, because it's in the metrics. Like I noted your measure of the green space was around a 1,000-metre buffer.
Yes.
Around the residential address. Can I ask how many of your elderly cohort were actually in residential housing, or were they in their own residential homes? Were they in residential care?
So all of our study participants were community dwelling and not in not in residential care homes. Those that moved into those homes between waves actually ended up not being included in the study. And so we had a number of people that moved out of the study between wave 1 and wave 2 because they were just too sick to continue in the study. And then in that age group, of course, we had a relatively large proportion of people with dementia. And so the way that the National Social Project works is they keep the same people in the study, but as they have attrition, they add people from the original sampling frame in.
Yeah, there's been a lot of these studies published, and it's easy to do with the secondary data, and it's worth doing, but the lack of associations, we may not get strong ones, is we have no idea as to the degree of contact these people actually have, the actual exposure to that green space. I think the holy grail in this work is we need to develop some better metrics, meaningful metrics of actual connectedness with that green space. It could be there, but they never go near it.
Oh, I agree. So
even when you do get an association, you think, well, is it real? Is it? And And it's like most environmental epidemiology, the weakness lies in our exposure metrics. So you've got, I love the idea with the biomarkers. I wish I'd had biomarkers for our work. We did a big study in Queensland based on the HILDA sort of survey, but we didn't have biomarkers. So you're ahead of us there.
Yeah. One of the interesting presentations that I saw at last year's ISEE was an approach to this that used Google Street View data to be able to determine what is actually visible. Because if you talk about an urban environment, you might be 500 meters away from by a Euclidean distance, but you could be an hour walk away, by the actual street kind of configuration. So I completely that is a significant limitation.
Can I jump in here? Hello.
Hello.
We can hear
Can
you.
you hear me?
Yep.
Hi. We've been doing. I've been doing some work with some Chinese colleagues from Guangzhou, where we are using the sort of Google Street View as a measure of exposure to the NDVI or to the greenness, and hopefully we'll be submitting a paper in the next week or so. So we'll keep you informed. But my other question was with your measurement of green space, did you only use NDVI or did you also have a sort of measures of exposure to parks and so on?
We only looked at NDVI.
So would that then be a reason why, when you looked at mediation, you had a very small proportion of mediation because of physical activity? Would you get something larger if you used exposure to a certain size of green space, for example?
I think that is an excellent point, and I agree that the imprecision in what the green space metric that we used actually is measuring might biasing our results.
Yeah, thank you.
Hi, I'm Michael Abramson, and I've just gone green, for which I apologise. I'll be very appropriate with this talk. Can you still hear me?
Yes, Michael.
Okay, I'm from Monash University, so I'm really fascinated by your results, Trent. As I tell my own students, one of the best things about research is that you don't always find what you expect. I just wondered about the mediation analysis, whether it might to some extent be confounded by differences where people from different racial groups live. I haven't spent very long in the US, but I have this idea of sort of crumbling inner urban areas where many black people live, where it's actually not safe to engage in physical activity. And I sort of have an idea that Native Americans are living on reservations. Now, maybe that's not the case in the 21st century, but I'd just be interested in your response.
Sure. One of the main reasons that we had a priori hypothesis around race was very apropos to your point, which is the kind of history of systemic racism in the United States has created very segregated neighborhoods, and often those neighborhoods have fundamentally different characteristics where people of color tend to live closer to roadways. They tend to live in areas that are much more polluted. They tend to live in areas that have lower green space. There are some exceptions to that, some regional variation, however. If we look in the US South, oftentimes we will see that there's a higher proportion of people living in rural, poor areas of color. And so I think that is an area that we're hoping to continue this work, is to start looking at specific regional differences and how those, how the living situation in those differences might be influencing some of our results. And I was unfortunately not surprised to find that urbanicity was associated with a significantly higher association in people of color. because most of the previous literature and our previous investigations of these data sets have found that. And I think that, you know, when we consider that that is independent of controlling for a number of area level socioeconomic as well as individual level socioeconomics, what we end up measuring there is probably something related to you know, race in the United States.
Thanks very much.
Trenton, it's Jane Hayworth here from the University of Western Australia. We've done some recent work on biomarkers and exposure to pollutants, and we did see a relationship between CRP and PM2.5, so an increase in CRP with increasing PM2.5. We also saw relationships with triglycerides and HDL cholesterol. So it's really interesting to hear your presentation, and because of the close link between pollutants and green space and distance to roadways.
I really appreciate you sharing that. In a previous study of this cohort, we looked at NO2 and PM2.5 as exposures and diabetes and hemoglobin A1C as outcomes, and found significant associations.
Yeah.
We do have a significant association between air pollution and CRP markers in this group as well. It is not a very large magnitude. I think it's smaller magnitude than much of the previous work, which is interesting.
Yeah. Okay, thank you.
Hi, Trent. Actually, I would like to share some of my recent work as well, working with biomarkers and specifically high sensitive C-reactive protein, but in a Chinese older adults. And I'm quite interested in your result because it's quite similar to what we found in the Chinese older adult cohort with the significant association with actually different pollutant, PM2.5, PM10, and PM1. We were quite lucky to look at such that association with PM1 and nitrogen dioxide as well. So we found it positively associated and significantly associated with increase of high sensitive CRP as well. So yeah, like it's just amazing that all the biomarkers research is just coming nicely together from different cohorts across the world. I just wanted to ask you something. I don't know if I missed it, but how did you measure the physical activity in your study?
Sure. The physical activity was measured in the interviews with individuals at the beginning of each of the waves, and then it was categorized into METs or metabolic equivalents, and then we, you know, had a continuous measure as well as we categorized them into different bins, and so it was based upon interview and then having that interview kind of converted directly into metabolic equivalents.
So like kind of using of the global physical activity questionnaire or something like that, and then like transfer it to METs and including that in the model, right?
Yes, yes. I do not know if that is the precise questionnaire that was used. At some point in time, I probably did know that, but such is life, right?
Okay, thank you. Thank you. So not sure if we have any more questions from our participants.
It's just Anne here. I'm really keen to see if anyone else is interested in working with me to help develop sort of a more sort of component index of connectedness or interaction with green space. I'm a part of an international study on blue space with Exeter, and that's the other thing. Blue space is a little bit different to green space, and there's unique associations there. And it's not, yeah, so as long as we rely on sort of remotely sensed measures, they're really blunt. But if anyone's got interest in, John, if you're working in Guangzhou, I'm working in Hong Kong, we need 3-dimensional green space measures of exposure, because people live in high rise, but the green space will be up on the 3rd floor. So it's really,
No,
it becomes
sure.
complicated, and they can live in really
And-
highly densely urban areas, but it only takes them 10 minutes by bus to get to a country park. So unless you've got some questionnaire data which actually asks them about their degree of contact or amount of time spent in different ways within green space, and if we're reliant just on secondary data, we're not going to get to these nuances of why, you know, what are the mechanisms of impact on these biomarkers. But I'm fascinated by it. So, and I need some colleagues to sort of brainstorm with me. So I'll organise a conference on the Gold Coast and you can all come up.
Great, Anne, thank you. It'll be wonderful.
Good.
And you're aware of Urban Monitor, which doesn't answer all your questions. It doesn't certainly get to the question of connectivity with green space, but in terms of being able to distinguish between trees and low vegetation is available through Urban Monitor, which is the CSIRO measure of green space. So that does give you a bit more than NDVI, I think, essentially.
And the HILDA survey, which is longitudinal, they had questions from the participants about what their perception of their green space was.
Oh, interesting.
Okay.
Which we found, a PhD student of mine did some really good mediation analysis on that connectedness and sense of that affective appreciation of green space in their outcomes. And Cleary, so I can send you those if you're interested. But excellent, it's good to see you all.
It seems like we're forming a collaboration in the webinar, like a national and international collaboration, which is, I think, something we're really keen in forming within CAL. So thank you so much, Anna, for your contribution.
Thank you.
So I think we're ready to wrap up. Trent, do you like to add anything, like we're more open for any new ideas or like collaboration opportunities, or like if you're running something through your division, we'll be more interested to attend and to be part of it. And thank you so much again for today.
Thank you. I really appreciate it. Yeah.
Thank you. Thank you, everyone. We really appreciate you coming today, and enjoy the rest of your lunch break. And thank you so much for you, Trent. Thank you. The recording will be uploaded on CAL website hopefully next week.
And with the slides, Mona?
Yes, it's just as if we're seeing it at the moment.
Excellent. Thank you.
Yeah, thank you so much.
Bye.
Thank you. Bye.
Thanks, Mona. Thanks, Trenton.
Thank you, Joel.
Okay, bye-bye.
Thank you, Trent. Thank you.